Hello everyone and welcome to our module on inflammatory bowel disease. Inflammatory bowel disease refers to two conditions that are both chronic autoimmune bowel diseases. The first one is Crohn's disease, the second one is ulcerative colitis. And both of these conditions have a relapsing remitting course where patients have flares and they have increased symptoms and they require more medication, and then the flare is followed by a period of remission. And both disorders can have somewhat similar symptoms. They both have recurrent episodes where symptoms get worse. They can both be associated with abdominal pain or bloody diarrhea. And we'll talk in a little bit about some of the distinctions between Crohn's disease and ulcerative colitis in terms of symptoms. In most studies, there's a slight female predominance to the incidence of inflammatory bowel disease. And the age of onset is usually going to be a young adult, ages 15 to 40. There are some studies that suggest a second spike of incidence in the range of 50 to 80 years of age. Both forms of inflammatory bowel disease are more common among Caucasians, and both forms are more common among patients with Jewish ancestry. We'll talk about ulcerative colitis first, and ulcerative colitis gets its name because in this condition there are ulcers that form in the colon, hence the name ulcerative colitis. The ulcers that form are caused by inflammation of the mucosa and sometimes the submucosa, but importantly, the full thickness of the colonic wall is not inflamed. That's a distinction between ulcerative colitis and Crohn's disease, which we'll talk about later. Ulcerative colitis always begins in the rectum, and then the inflammation works its way upwards. And so many patients develop left lower quadrant pain because the sigmoid colon is commonly involved since it's right next to the rectum. And then lastly, remember that this condition is called colitis, so it only involves the large intestine or the colon, it never involves the small intestine. Crohn's disease, as we'll talk about later, commonly involves the small intestine. The clinical features of ulcerative colitis include bloody diarrhea. Because there's always inflammation of the rectum, this can lead to fluid leaking into the bowels, causing diarrhea, and the fluid is usually bloody because of the ongoing inflammation. Tenesmus is another classic symptom. This refers to the frequent feeling that you need to evacuate the bowels and move your bowels. And then lastly, abdominal pain is common, often in the left lower quadrant. When you examine the colon in patients with ulcerative colitis, either through a colonoscopy or as a pathology study after the colon has been removed, there are a number of classic findings that you should be aware of. And the first one is the presence of pseudopolyps. This is caused by the healing of ulcers in ulcerative colitis. This is what it looks like on the screen here. So you have the mucosa layer and then an ulcer forms, but when the ulcer heals, it often heaps up out into the lumen of the colon, and that creates these little polyps that you see in this picture on the slide here. Another classic finding is the lead pipe appearance of the colon when you image the colon either by X-ray or CT scan. This is caused by the ulcers destroying the haustra of the large bowel. On the left is a 3D reconstruction of a patient with ulcerative colitis, and notice how straight the bowel is. It doesn't have these indentation of the haustra that it should have. That's called the lead pipe appearance. You can also see it on the X-ray on the right in a patient who has taken contrast. You see that straight lead pipe appearance of the colon with loss of the haustra. When you do a biopsy of the colon in a patient with ulcerative colitis, what you're going to see is evidence of inflammation that's limited to the mucosa and the superficial submucosa, but importantly, it's not going to be transmural inflammation because that only occurs in Crohn's disease. Another classic finding is crypt abscesses. This refers to neutrophils that have invaded the crypts. You can see one in the middle of the slide here. Also in the slide on the right, you can see all these white cells, these inflammatory cells that are limited to the mucosa and the superficial submucosa. In another video, I talk about toxic megacolon in detail, but I just want to mention it here because it's a rare complication of any form of inflammatory colitis. That could be ulcerative colitis, it could also be infectious colitis. In toxic megacolon, there's a cessation of colonic contractions, and as a result, the bowel begins to dilate rapidly and the walls of the bowel thin and they're prone to rupture, which can lead to perforation. So in a patient with a history of ulcerative colitis who develops abdominal pain and abdominal distension and possibly evidence of shock, you should think of this diagnosis as toxic megacolon. Now let's talk about Crohn's disease. So like ulcerative colitis, Crohn's disease is an autoimmune condition that affects the bowel. In contrast to ulcerative colitis, however, in Crohn's disease, the entire wall can be affected by inflammation. This is considered a transmural process. Also, Crohn's disease is famous for being able to affect any portion of the GI tract. It's said to potentially involve anywhere from the mouth to anus. In some cases, you can even see oral ulcers. So this is another distinction from ulcerative colitis, which is always confined to the colon. Even though Crohn's disease can involve anywhere from the mouth to anus, the classic location is the terminal ileum of the small intestine. And so because the terminal ileum is important for absorbing lots of nutrients, patients can develop clinical features of malabsorption when they have Crohn's disease involving the terminal ileum. This is also the location where many vitamins are absorbed, including vitamin B12, so you can see vitamin deficiencies in patients with Crohn's disease. Because Crohn's disease involving the small bowel can lead to malabsorption, patients can have non-bloody diarrhea similar to patients with malabsorption disorders, and then involvement of the ileum can also lead to right lower quadrant pain. Some other things to know about Crohn's disease: it often spares the rectum in contrast to ulcerative colitis where the rectum is always involved. And then Crohn's disease often skips sections of the intestines. If you look at the bottom right side of the screen, the red areas are inflammation from Crohn's, and you can see that there is an area that's involved in the colon, and then a normal section, and then another area. These are called skip lesions, a classic feature of Crohn's disease. Some of the clinical features you can see of Crohn's disease are on this slide. We mentioned some of these earlier. Diarrhea often occurs, and it can be non-bloody because it's not due to inflammation of the rectum like you see in ulcerative colitis. It's due to malabsorption. Patients also commonly develop abdominal pain, clinical features of malabsorption of nutrients, and weight loss. On gross examination of a section of bowel involved with Crohn's disease, one of the classic findings is a cobblestone mucosa. This is a picture of what it looks like on the right. And what's happening is the raised areas are normal mucosa, but there are depressed areas which are inflamed from Crohn's disease. And this is thought to resemble cobblestones like shown on the screen, hence the name cobblestone mucosa. When you do a biopsy of a section of the intestine that's involved in Crohn's disease, the classic finding is the presence of granulomatous inflammation with formation of non-caseating granulomas like what's shown on the slide here. This feature defines Crohn's disease because you don't see granulomas in ulcerative colitis. Other than granulomas, you can see other findings similar to ulcerative colitis like neutrophils and inflammatory cells, but in contrast to ulcerative colitis, they will involve the entire wall of the colon, not just the mucosa and submucosa. Another finding you can see in sections of bowel involved in Crohn's disease is the presence of creeping fat. As the transmural inflammation heals, fibrous tissue condenses around the bowel, and this pulls fat around the bowel, and it can potentially wrap around the entire bowel wall. So when you excise a stretch of bowel from a patient with Crohn's disease, often you will see that it's surrounded by fat, and that's called creeping fat. Another finding in bowel involved in Crohn's disease is the presence of strictures within the bowel. So healing of the inflammation leads to the growth of fibrous tissue, and it can become very dense and narrow the lumen of the bowel. And when you do barium imaging or other contrast imaging of the bowel, this can sometimes produce what's known as the string sign. This is shown on this slide here. So the contrast is reduced to this narrow string of contrast, and that's because the bowel in this patient with Crohn's is filled with scar tissue that's very dense, and it's not allowing the entire colon to fill with contrast like it should. It should look more like this section of bowel up here, but it's narrowed down to a thin sliver, to a string, because of the dense fibrous tissue. Because the inflammation of Crohn's disease is transmural and involves the entire wall of the intestine, potentially a hole can open in the wall of the intestine, and the lumen of the bowel can end up connecting to some other structure. This is called formation of a fistula. There are many different types of fistulas that can form in Crohn's disease. Some of the common ones are shown on this slide. A fistula between the bowel and the skin around the anus is called a perianal fistula. A fistula between the bowel and the abdominal wall is an abdominal fistula. And you can also see a connection form between the lumen of the bowel and the bladder. This is called an enterovesical fistula. In addition, patients with Crohn's disease commonly develop kidney stones, and usually the stones are calcium oxalate stones. The reason this happens is because patients who have Crohn's have high levels of oxalate in the plasma. Calcium and oxalate are normally bound in the gut, like what's shown on this picture here, and when they're bound, they're poorly absorbed, so you can only absorb so much calcium and oxalate when the two substances are bound together. But in patients with Crohn's, when the small bowel is involved, there's often fat malabsorption, and fat binds calcium. This leaves oxalate free in the gut to be absorbed, and that raises the plasma levels of oxalate, and that goes on to cause a higher frequency of calcium oxalate kidney stones. To diagnose any form of inflammatory bowel disease, it's high yield to know that you have to exclude other causes of intestinal inflammation. Before you can say that a patient has autoimmune inflammation of the intestines, you have to rule out that they have an infection causing that inflammation. So tests that are commonly sent in patients who you suspect of having IBD include a C. diff toxin test, stool cultures for these bacteria, microscopy for ova and parasites, and a Giardia stool antigen. And the goal of all these studies is to exclude infection as a cause of intestinal inflammation. To make a diagnosis of ulcerative colitis, a patient has to have chronic diarrhea for more than 4 weeks, and they need evidence of chronic inflammation of the colon on colonoscopy. Usually this involves a biopsy. And then beyond these two things, you have to exclude other diagnoses, like all the things we talked about on the last slide, which involve ordering these tests for the patient. Crohn's disease can be trickier to diagnose. There are a lot of different ways to make the diagnosis. First of all, patients have to have chronic abdominal pain and/or diarrhea. Because lesions often develop in the small bowel, there's usually small bowel imaging done with things like MRI, CT scan, or barium x-rays, and you're looking for evidence of inflammation anywhere in the small bowel, but especially in the ileum, because that suggests Crohn's disease. You can also do a colonoscopy and advance the colonoscope into the terminal ileum to take a biopsy, and this is another way the diagnosis can be made. So usually it's a combination of different imaging tests, plus the patient's clinical history, plus excluding other diagnoses. This all comes together to make a diagnosis of Crohn's. Both forms of inflammatory bowel disease, because they are autoimmune conditions, can lead to inflammation outside the GI tract, and this can cause a number of extraintestinal features of IBD. In the skin, there are two conditions often seen in patients with inflammatory bowel disease. One is pyoderma gangrenosum, which is a deep necrotic skin ulceration. I'll show you a picture of this in a minute. The other is erythema nodosum, which is inflammation of fat tissue under the skin. We'll also see a picture of this on the next slide. In another video, I talk about primary sclerosing cholangitis, which is an inflammatory condition of the biliary tree. This is strongly associated with inflammatory bowel disease, especially ulcerative colitis. Many patients who develop primary sclerosing cholangitis also have ulcerative colitis. Joint pain is a big problem for patients with inflammatory bowel disease. They can develop peripheral arthritis of the hands, but also they can develop inflammatory back pain from spondylitis and sacroiliitis. And then finally, in the eyes, uveitis and episcleritis are inflammatory eye conditions that can be seen in patients who have inflammatory bowel disease. This is a picture of pyoderma gangrenosum shown on the left. You can see it's a deep necrotic skin ulceration. On the right is an example of erythema nodosum. It presents as these red, painful patches, and it's caused by inflammation of the fat under the skin. There are two antibody tests sometimes used when evaluating patients with inflammatory bowel disease. The first one is p-ANCA. This is an antibody that's commonly seen in patients with vasculitis syndromes like Sjögren-Strauss or microscopic polyangiitis. It also occurs in patients with ulcerative colitis. About 60 to 80% have this antibody. You can sometimes see it in patients with Crohn's as well, but the frequency of p-ANCA in Crohn's is much, much lower than the frequency of seeing p-ANCA in patients with ulcerative colitis. Anti-Saccharomyces cerevisiae antibodies, or ASCAs, are antibodies to Saccharomyces cerevisiae, which is a type of yeast. And elevated levels of antibodies to this type of yeast are seen in patients with Crohn's disease. Studies have found anywhere from around 40% to 80% of patients with Crohn's have these ASCA antibodies. So neither of these tests are diagnostic. They're not reliable for routine clinical use, but they're sometimes used to distinguish forms of IBD, because p-ANCA makes it more likely that a patient has ulcerative colitis, and ASCA antibodies make it more likely that a patient has Crohn's. Let's talk about adenocarcinoma of the colon. There's an increased risk of developing this malignancy in patients with ulcerative colitis. They have ongoing inflammation of the rectum and the colon, and that raises the risk of adenocarcinoma. How high the risk is raised in patients with UC is based on two key factors. The first is the duration of disease. It takes about 10 years from the onset of disease for most cancers to form. So patients who were just diagnosed with ulcerative colitis a year ago are at low risk, whereas patients who have had ulcerative colitis for many years are at higher risk. The other important risk factor is the extent of disease, meaning how much of the colon is involved in ulcerative colitis. The more disease, the more risk. So as we talked about earlier, ulcerative colitis always begins in the rectum, but then it spreads to involve the left-sided colon and then the right-sided colon. If there's involvement of the right colon, this means the patient has a high burden of disease. So patients with right-sided colitis, or so-called pancolitis, meaning both the right and left side are involved, these patients have major risk factors for developing adenocarcinoma. So because of the risk of adenocarcinoma, screening colonoscopy is recommended for patients with ulcerative colitis, and we'll talk about that in a second. And sometimes these patients require colectomy to reduce the risk of developing adenocarcinoma when there are advanced lesions in the colon. For patients with Crohn's disease, there's an increased risk of adenocarcinoma only if the colon is involved. So when patients with Crohn's have evidence of colon involvement, then they also need surveillance colonoscopy, similar to patients with ulcerative colitis. In contrast, for patients with Crohn's who only have involvement of the small intestine or areas outside the large bowel, those patients do not need surveillance colonoscopy. Shown on this slide are the recommendations for screening for adenocarcinoma in patients who have ulcerative colitis. If the patient at the time of diagnosis has pancolitis, meaning inflammation of the left-sided colon and also the right-sided colon, then that patient should have an initial colonoscopy to screen for colon cancer 8 years after the onset of disease. In patients who have left-sided disease only, these patients are at lower risk, so their first colonoscopy is not necessary until 12 to 15 years after the onset of ulcerative colitis. And once you begin screening for adenocarcinoma, colonoscopy is usually repeated every 2 to 3 years. Let's talk briefly about smoking. So believe it or not, smoking improves the outcomes in ulcerative colitis. It's not clear why this is the case, but patients who have ulcerative colitis who smoke have fewer flares, and some patients have a flare of their disease if they quit smoking. In contrast, for patients with Crohn's, smoking worsens outcomes, and this is the only modifiable factor. So when patients have Crohn's disease and they ask, what can I do so that I don't get a flare of my disease? The answer is that they shouldn't smoke, or if they do smoke, they need to quit smoking. The treatment of inflammatory bowel disease involves medications and surgery. For medications, when patients initially present with the signs and symptoms of IBD, you need to do what's called induction of remission. This usually involves corticosteroids to tamp down the inflammation and resolve the patient's symptoms. After this, there are different groups of drugs that can be used to maintain remission and keep patients from having flares. Surgery is necessary if patients develop evidence of adenocarcinoma or if they have complications of IBD. For example, patients with Crohn's who develop fistulas or other complications, they often need surgery as a component of treatment for their disease. Shown on this slide is a list of some of the commonly used medications for maintenance of remission of inflammatory bowel disease. I won't go through all of these medications in this video, but we'll talk about a couple of the ones that are commonly used so you understand how they work and what their side effects are. We'll start by talking about sulfasalazine. So sulfasalazine is not absorbed, and when it reaches the colon, colonic bacteria break it down into a substance called 5-ASA. 5-ASA is 5-aminosalicylic acid, and it's structurally similar to acetylsalicylic acid, which is what aspirin is. So this is a great drug because it's not active until it reaches the colon, when the colonic bacteria form the 5-ASA, and this metabolite will function like aspirin and it will decrease inflammation in the colon. The problem with sulfasalazine is it has a number of side effects that often make the drug intolerable for some patients. First of all, it can cause GI upset symptoms like nausea and vomiting, and this is a common reason that patients have to discontinue the drug. Sulfasalazine is also a sulfonamide type drug, so it can cause hypersensitivity reactions like rash, and this also causes some people to be unable to tolerate the medicine. And then in men, sulfasalazine causes oligospermia. The mechanism is unclear, but the sperm count comes up if you stop taking the drug. And this can be a big problem for young men trying to conceive while taking this therapy. As we talked about earlier, patients from ages 15 and up often develop Crohn's disease or ulcerative colitis. Many of those patients are men and they want to have children, but they can't if they're taking sulfasalazine. Because sulfasalazine has so many side effects, the drug that's often used in the modern era instead of sulfasalazine is mesalamine, which is just the 5-ASA component of sulfasalazine. It's the active component that you derive from sulfasalazine when colonic bacteria break down the molecule. Because 5-ASA does not contain the sulfa component of sulfasalazine, it's much better tolerated with fewer side effects, but much of it is absorbed in the jejunum. And so for patients who have disease beyond the jejunum, especially in the colon, there's less delivery of the drug. So to get around this problem, 5-ASA is often administered as a modified compound that resists absorption of the drug in the jejunum. There are delayed release capsules of 5-ASA. They go by names like Azicol and Pentasa. There are also modified 5-ASA molecules. These drugs have names like balsalazide or osalazine. But the idea behind all these medications is the same. It's to deliver the active component of sulfasalazine without using the sulfasalazine molecule and get that active component into the colon. You can also administer 5-ASA rectally. This is called topical 5-ASA, and this will directly administer the drug to the colon to decrease colonic inflammation. And that concludes our module on inflammatory bowel disease.